Hey guys, welcome back for another video. In this video, I'll be basically doing a presentation that I did for my externship at UPMC this past June. It was a 10-minute long presentation, but in this video, I'll kind of be a little bit more casual and kind of explain the things that I wish I could have, but didn't really have time to do so during my presentation. So it'll be a lot more educational for you guys. Before I get started though, I do apologize for my lack of video output. I've been a little bit busy with the externship and all the preparations that I need to do for day-to-day activities as an extern, just like reading literatures, reading books, and kind of working out kind of thing just to keep me sane. So I do apologize for that, but I'll be a little bit more diligent in making these videos for you guys. So still, I will still try to make at least one video per week, so we'll see how that goes. But anyway, so this presentation, we were assigned a group topic of nutrition, and in that topic, I was basically not assigned, but I decided to do a subtopic of basically a diet for the patients that are in the hospital. So here I go. So the outline of my presentation, I'll start by talking about what is a malnourished patient. How do we really identify patients who are potentially at risk for malnourishment? What's the ideal nutrition for those patients? And one of the complications or things that you have to keep in mind as a physician when you're feeding malnourished patient, called refeeding syndrome. A different route of feeding these patients, oral, enteral, or parenteral. So the first topic, hospital malnutrition. So hospital malnutrition is briefly defined as an imbalance in nutrition, and this can be either an excessive or under nutritional intake. In a hospital setting, it's been recorded that malnutrition rate is approximately 40%, which is pretty high considering their patients are in a hospital setting, and you would think that as a health professional, we are very aware of what the patients need to expedite their healing process. But actually, it's been recorded that it's approximately 40%. And in certain places in the world, sometimes it even exceeds that. So as a physician, you have to be super vigilant in terms of making sure that the patients are getting right amount of nutrition to speedy recovery. And apparently, so obviously, the malnutrition is associated with impaired wound healing, muscle wasting, and longer hospital stay, which is going to cost more money and also increase mortality. So National Institute for Health and Care Excellence, NICE, put out a guideline kind of telling physicians how to identify these patients that are potentially at risk for malnourishment. BMI less than 18.5 or an unintentional weight loss greater than 10% within the last 3 to 6 months, or any combination of those, which is BMI 20 and unintentional weight loss greater than 5% within the 3 to 6 months. We'll kind of give you a general give a sense to a physician that a patient may potentially be at malnourished risk. Generally, hospitals, if they were to assess subjectively whether or not a patient is malnourished, they do a questionnaire that they provide to the patient. But there's not a standardized questionnaire that everyone uses. Each hospital uses a different questionnaire, so the survey is not really accurate, and there hasn't been any study indicating whether one survey was better than the other one. So this NICE guideline is kind of neat in a way that it kind of gives you general baseline in order to identify malnourished patient. So in order to be plan to use patient, we have to know what is the appropriate amount of nutrition. For anyone is basically 25 to 35 calories per kilogram of the body weight for a total day of the energy. And if the BMI is over 25, indicating that the patient is maybe a little bit overweight, then you want to kind of lean on the lower end of that spectrum. And out of those protein intake, out of those nutrition calorie intake, you want to make sure that protein comprises of at least 0.8 to 1.5 grams of protein per kilogram of the body of the patient per day. And then obviously adequate fluid and minerals, micronutrient, and fiber when it's appropriate. So now that we know how to identify a potentially malnourished patient and also what appropriate nutrition they need, let's talk about one of the complications that arises when someone feeds a malnourished patient too rapidly. So it's what we call refeeding syndrome. And refeeding syndrome is basically metabolic and clinical changes due to aggressive nutritional rehabilitation. Really, basically what happens is when a patient is malnourished for a little bit of time, their body is basically eating away the muscle. They are in a catabolic state. They are basically breaking down structures of the body to get energy. But a rapid intake of carbohydrates and fat from food will instantly change the body into an anabolic state with a spike in insulin. And as you guys know, insulin basically is an anabolic kind of hormone that allows rapid uptake of cellular uptake of electrolyte like phosphate, sugar, potassium, magnesium, and such. And so what ends up happening is the body will go into a physiological hypophosphatemia, low phosphate, low potassium, magnesium, and also the kidney will start holding onto the fluid. And this generally happens 20 to 47 hours of feeding. And obviously these physiological change will elicit a body to go into complications that are related to cardiovascular, neuromuscular, and other stuff. So it's terrible. So a study from Stanford stated that a recommended initial calorie input should be about 20 kilograms per body weight of kilogram per day, and want to gradually increase that calorie intake to 10 to 25% until the calorie goal is met. And obviously other fluid and sodium should be a little bit restricted because refeeding syndrome basically also one complication arises from fluid holdup. The author of the study also stated that one of the most important things when treating a refeeding syndrome is not really the calorie, but it's actually the electrolyte deficiency that occurs with the rapid insulin spike. So as an example, you could replenish phosphate by giving them 0.08 to 0.16 millimole per kilogram for adult, and for a little bit higher value for a child. So, and also another sign to kind of know whether or not you're not feeding them too rapidly is you don't want any weight gain more than 1 kilogram per week. So this is basically, like I said, it was put out by Stanford, study done by Fuentebella at 2009. So now that we talked about potential risk of from refeeding syndrome, let's talk about how we can actually feed the patient. So there are obviously different routes, oral, enteral, and parenteral. Oral is basically what it sounds like, you go through the mouth. Generally in the GI community, if they believe that if you have a functioning gut, you want to use it. So the oral is generally recommended. But if they have any problem with swallowing or dysphagia, then you want to go to enteral tube. Enteral tubes still go through the GI tract, but they have a different starting point than oral by insertion of tubes. And if the GI absorption is not appropriate or it's not really working well for certain patients, then you want to go parenteral route. And I'll talk about basically diet associated with those routes and kind of other formulas that are available with them. So the first kind of diet I want to talk about is MPO diet. It stands for nil per os, from Latin, I believe, and it's basically a diet prescribed to patient who's going surgery, and it's basically they cannot eat or drink anything 8 hours, 2 hours respectively prior to the surgery date. And it's basically to prevent any pulmonary aspiration of stomach contents during general anesthesia. Basically, they don't want to choke on their own vomit. So that's why before anyone goes into surgery, MPO diet, if undergoing general anesthesia, they need to do an MPO. Now, after a clear liquid diet is generally used for preparation of surgery for a patient who's about to go to surgery, like the day before, or used for first post-operative meal. It's basically what it sounds like. It's any diet that basically you could see through, which includes like a fruit juice, tea, consomme, or anything like that. Something that you could see through. And it basically doesn't really stimulate much of the digestive system. Full liquid diet is basically a step above clear liquid diet, and is basically a little bit more heavy on the macronutrition. It allows digestive tract to work a little bit harder, but it basically eases the patient into more regular food, essentially. Now I'm going to talk about a little bit disease-specific diet. First one is cardiovascular or heart-friendly diet, heart-healthy diet. And the idea is you want to reduce the intake of fat, cholesterol, sodium, and calorie to basically prevent or impede the atherosclerotic plaque that is building up on some of these patients' vessels. And also sodium and calorie is basically to reduce weight loss, which could be a comorbidity, and also just fluid retention from sodium. And another way to kind of decrease plaque buildup is by fiber intake. So it's recommended that patients who are at risk for cardiovascular kind of increase their fiber intake about at least 30 grams per day. Gastric bypass diet is generally indicated for a patient who has gone gastric bypass surgery, basically just surgically removing part of the stomach. And after the patient goes through that surgery, they need to kind of get used to the different sides of their stomach and just used to eating differently. So you start first phase, you start by clear liquid, just like fruit juice or anything like that. Usually it lasts for a couple of days after surgery. Phase 2 is a low-fat, full liquid, basically like an Ensure, kind of a little bit more heavy than the clear, macronutrition heavy than the clear liquid, but it's basically, it lasts about 1 or 2 weeks, and then patients get discharged on that. And then at home, they could kind of start eating puree diet, kind of soft, blenderized food. And then at the end, phase 4, you end up with a regular diet, and just you could go back to regular food essentially about 8 weeks after the surgery. So gradual, you could see from the slide over here that you could gradually increase your fluid, increase the workload that the stomach has to do by changing the food that that you eat. Gluten-free diet is basically, everyone knows this already, is just indicated for celiac disease and then a wheat allergy. Gluten is like a lot of protein on wheat that kind of sometimes irritates the small intestinal lining of certain people. So patients who have celiac disease or wheat allergies want to avoid this kind of a diet. Next is a low sodium diet. The association between high sodium intake and hypertension has been shown in many literatures. As one example, there was a study that was done by Dahl and Love, where they showed low, medium, high sodium intake of people, and they found out the incidence of hypertensive cases were high in high sodium intake, about 10% of the time, and there was a significant difference between the sodium intake low and high. So the study didn't really exactly specify how much sodium they're talking about, but they kind of estimated that low sodium diet would comprise about 2 to 3 grams, and high was a little bit like 5 to 7 times more than that. So basically, for low sodium diet is you want to lower the blood pressure, and that's occurring because of fluid retention from sodium. So you want to, if a patient has high blood pressure, you generally want to limit the sodium intake from 1 to 2 grams a day, and even lower if that's possible. Now, consistent carbohydrate diet is a diet specifically designed for a diabetic inpatient. And oftentimes when diabetic patients come to the hospital, they get bombarded with lab orders and surgeries and all the good stuff that often disrupts their diet or their nutrition. So what ends up happening is the glycemic is out of control, and this diet, consistent carbohydrate diet, is specifically designed to basically maintain that glucose control, and is recommended to control it to 110 milligrams for critically ill patients, or non-critically ill patient. The range could be about 90 to 130. So how do they do it? The idea is to basically give them the same amount of carbohydrate every single meal. So it's not about how much of carbohydrates they get, but it's more that each meal has to have the same amount of carbs. So as an example here, they're shown in the picture is about 70 grams every meal. It could be in any form, really. Clear liquid, full liquid, or mechanical. There's some other stuff that I cut it out, but basically this consistent carbohydrate diet wants to feed the patient same amount of carbohydrates so that their glucose doesn't spike or go too low. Low protein diet is indicated for chronic renal disease. There's been a retrospective study about including 7 randomized trials showcasing that 0.3 to 0.6 grams of protein based on the kilograms of the body per day is adequate for a chronic renal failure patient. And the idea is that the protein is processed through kidney, And if the kidney is not working properly, then you want to decrease the workload by decreasing protein intake. So and the study shown that consuming 0.3 to 0.6 kind of decreased the renal death by 40%, and they defined renal death by patient who passed away and a patient who went to dialysis during the duration of the study, or patient who had to get transplantation of the kidney during the study. But this is a little bit different from patients who are on dialysis. For renal patients who are on dialysis, you actually need to eat a little bit more protein because it is getting filtered out, I believe is what I read. So it's a little bit different from that. So for chronic renal failure patient, kind of lower the intake of protein to about 0.3 to 0.6 grams per kilogram per day. Now the next route I will talk about is enteral route. As you can see from the picture, it's basically an insertion of tube to a certain place in the digestive tract. It's a different starting point. There's a nasogastric tube, nose to stomach, nasoduodenal, nose to the duodenum, gastrotomy tube directly to the stomach, jejunostomy. So these tubes are generally, I've seen it been inserted by the interventional radiologist. They do it, that's their small procedure that they do. So after they insert it, you just basically put in blenderized food into the tube and feed them. So there's different formulas that are available for these enteral route. First one I will talk about is polymeric preparation. It's basically just a wheat protein shake or just blenderized food. That's basically requires digestion from the stomach. It's basically a puree kind of food. There's monomeric and semi-elemental. These formulas are kind of already broken down form, and they include medium chain triglycerides, amino acids, but the idea is that they are kind of already broken down. There's reviewed from there was like a gastroenterology series. One of the articles talked about if there's any difference between polymeric versus the monomeric / semi-elemental. In terms of the macronutrition, there is not much of a difference, but monomeric and semi-elemental is purely indicated for patients that have malabsorptive tract. So it basically is easier to kind of absorb monomeric and semi-elemental because it's already broken down. Next is a fiber-enriched enteral formula. Again, the idea is that one of the complications of side effect of enteral route feeding is diarrhea because the food is already blenderized. This food is basically a liquid. So you could imagine diarrhea being one of the complications. So there people thought that, hey, if we give a fiber-enriched formula, which kind of increases colon bacterial population and stool mass, will that decrease the rate of diarrhea? There's a controversial study indicating whether or not it does affect the rate of incidence of diarrhea. So it's still debatable whether or not fiber-enriched formula does anything different than just a normal enteral formula. People also thought about calorically dense dietary formula, CDDF, and there's a study showcasing, because think about it, if patients who are in a hospital who are undergoing severe stress in terms of healing because their body is traumatized, ideally if you give more nutrition than the average enteral formula, it will be somewhat helpful, logically speaking. So there's a study done to see if a CDDF, calorically dense dietary formula, would actually offer any additional benefit to trauma or surgical patients. What they found out that it actually does not. It does not matter if they are eating CDDF or just a normal formula. In actuality, CDDF actually worsens hospital outcomes by prolonging the time that the patient can get off the mechanical ventilator and then the longer stay. And the author of the article reasoned that it may be because CDDF has poor glycemic control due to low fiber content and a high medium chain triglyceride, which acts like a glucose, and also a high omega-6 to omega-3 ratio. You want omega-3 to be high, not omega-6. So they thought that's potentially the explanation why calorically dense dietary formula may have performed worse in trauma and surgical patients. So it's still debatable whether or not CDDF is useful or not. Next is a enteral formula for diabetic patients. A study compared glycerna, enrich, ensure, complete, and some other proprietary formula. And they found that glycerna to be the best had the lowest glucose response, and that's because it had lowest carbohydrate concentration in the enteral formula. While the other packages had about 100 to 140 grams per liters, glycerin had 70 grams, so it's expected that it will have the lowest glucose response. So, I mean, the study was on at UCLA. It kind of showed, you kind of expected the outcome to be the glycerin being the best one because it had the lowest concentration of carbohydrates, but nonetheless, they compared with other products, and glycerin came on top. Now, the last route I want to talk about is parenteral route. It basically skips the digestive tract and goes straight to your bloodstream. It's generally insertion through the peripheral veins. Example is shown here, and it's going through the subclavian vein, and it's basically a super. They are in a macro, small molecular, like broken up parts that could be easily absorbed. That's the idea about parenteral routes. So all the formula will be basically small molecular, already in like an amino acid kind of level. And parenteral route, the advantages, first of all, the disadvantage is the most expensive route. You have to not only put in a specific line to go through to the venous system right away, so it's expensive, and the formula alone is also expensive too because it has to be specially created. But the advantage is that a parenteral route can control the calorie pretty well compared to the other routes because it's like kind of not like made in the laboratory style. That's the impression I got. They could have a high dense calorie delivered through the parenteral route. But one thing to take into consideration when you are using parenteral route feeding, you need to think about stress factor and activity factor. So stress factor is basically if a patient is undergoing a certain amount of stress, like infection, fracture, or fever, then you need to increase the calorie by a certain percentage, as shown in the slide. And if the activity is basically kind of a similar idea, if the patient is walking around and active, then you need to increase the calorie to accommodate for that extra expenditure of energy. So you need to think about that for a parenteral route. So it's a good way to kind of deliver a high calorie nutrition, although it's a little bit more expensive. So the one example I want to talk about parenteral route is a parenteral nutrition for treatment of severe hyperemesis gravidarum, or basically a severe morning sickness. And for these mothers who have severe morning sickness, they lose so much fluid that they are basically losing nutritional value in their body. They have significant weight loss from excessive fluid loss that ultimately endangers the fetus. And there's a study showing that administration of free amine and dextrose parenterally was able to restore the weight of the mother and put the fetus back into a proper track to basically have healthy embryonic growth. So it's like a useful way a parenteral route can be used for treatment of severe morning sickness for these mothers. So that's it for my presentation. I hope you guys enjoyed this video. It's a little bit long. It's a lot of dense information that I kind of skipped over, but I just wanted to pick out the meat of each kind of topic so that even though podiatrists aren't really going to be, prescribing nutrition and all that, but knowing this information will allow a better kind of sense of, if a patient are they getting the right care at a hospital and kind of expedite the healing process and reduce complication. So again, thank you for watching. I hope you guys tune in for our next video. Hopefully it'll be out in a week. It'll be, I don't know, I've been reading some journal articles, so I think I would like to do a certain topic presentation again. Not for like a specific external presentation, but just a general topic, just has kind of an open forum for discussion. Tune in for next time, and thanks for watching again. Have a nice day, guys.